So what are the types of bones that we know of? The anatomic classification is we classify the bones into long and flat bones. So the long bones are bones like tibia, femur, forearm, etc. These are examples of long bones which have the three parts that we expect of them: diaphysis, metaphysis and epiphysis. Flat bones include bones like the skull, scapula and the pelvis. Based on structure, they are divided into macroscopic bone, macroscopic classification and microscopic classification. Macroscopic classification includes cortical bone and cancellous bone. Microscopic includes lamellar bone and woven bone, and we will go into a little more detail about these things in the next few slides. So the long bone is further classified into diaphysis, metaphysis and epiphysis. So diaphysis is the central portion of the bone which is made up of very thick cortical bone with central canal in it. Metaphysis is in between the epiphysis and the diaphysis. It is made up of thin cortical bone, more of spongy bone. Therefore, it is a little more weaker as compared to the cortical bone and can be more prone for fractures. So metaphysis is more prone for fractures because of the fact that it has a thin cortical bone and more of spongy bone as compared to the diaphysis. The epiphysis is towards the joints. It contains a covering that is known as cartilage, which you have discussed in your anatomy and histology classes. We will further discuss it in our future modules. And the epiphysis also is made up of thin cortex and spongy bone, but the weak point is usually the epiphyseal plate that is seen in children, and this continues to be the weak point in adults where fractures are very common. So next, moving on to the cortical bone, it forms 80% of the skeletal structure. It is metabolized slowly because it is well formed and it does not need to turn over at a very high rate, and therefore the turnover rate of cortical bone is very slow. It has high Young's modulus. What is Young's modulus? So what is Young's modulus? Hi students, welcome to Plexus Ortho Exam Corner. Here we are going to start with the module 1, which is basic bone histology and physiology. We are going to go into a bit about the topic, and we are going to discuss a few questions in relation to the topic as well. Young's modulus is stress by strain. Young's modulus is stress by strain that indicates the amount of stress that is applied on a certain area which is required to change or modify the object. So cortical bone has a higher Young's modulus as compared to cancellous bone. This is very important concept. So the cortical bone is made up of osteon is a subunit of the bone. It contains a central canal containing vessels, arteries, veins and nerves in them. And these canals that are longitudinal to the bone is called as the Haversian canal, whereas canals which are transverse to the long axis between two osteons is called as a Workman's canal. And the lamellae or the osteon are limited by what is called as the outer limit is called as the cement lines. And there is bone formation in a concentric lamellar fashion around the canal, and this is called as the lamellae. And then we have lamellae in between the osteon, and this is called as the interstitial lamellae. So basically an osteon is the last subunit of the bony structure. It contains a central canal which contains arteries, veins and nerves, and it contains concentric lamellae which are organized around this Haversian canal, which is in longitudinal axis to the cortical bone. Canals in the transverse axis is called as Workman's canal, and in between these osteon is called as interstitial lamellae. This is the basic anatomy of a cortical bone along with the osteon. Cancellous bone has lower Young's modulus because it is more susceptible to stress. It undergoes more change. It is more elastic, and therefore remember it has lower Young's modulus. Cortical bone is harder, H for H, harder, higher Young's modulus, and less flexible. Cortical bone has higher Young's modulus and also less flexible, whereas cancellous bone has a lower or Young's modulus and is more flexible. Okay, it has high turnover because the stress is from multiple directions, and therefore the bone remodels very rapidly and turnovers in a rapid fashion. 30 to 90% of the bone is porous in structure, and this porosity increases in osteoporosis, and when the porosity increases, that is what is called as osteoporosis. So osteoporosis is a defect in the quantity of bone and not quality of bone. Next, coming to the microscopic structure in the bone. Microscopically, the bone can be divided into two types: woven bone and lamellar bone. Woven bone is immature bone and seen in pathological conditions. So what are the pathological conditions that you see woven bone in? You can see in osteosarcoma. other tumor or tumor conditions where the bone is producing bone in abnormal fashion. There is no relation to stress lines, and they have high turnover, and they cannot take weight. So they are more flexible, weaker, and fracture very often. So these are the conditions where you see pathological bone formation, which is called as woven bone. The other physiological condition in which immature bone is or woven bone is formed is in fracture healing. So in the callus formation, there is woven bone formation, which is not oriented along stress lines, and therefore it causes not grow along stress lines. It is more flexible and weaker. This is a physiological condition in which woven bone is formed, whereas a pathological condition in which woven bone is formed is called as osteosarcoma or other tumors where this can occur. It has more osteocytes per unit volume. Lamellar bone is secondary bone created by remodeling of the woven bone. So all the normal bone, including the bone that is seen in cancellous and cortical bone, is the lamellar bone. It is organized and more stress oriented. There is less turnover, and it is stronger and less flexible than the woven bone. So basically we have seen the classification of bones. The anatomic classification is long bone and flat bones. The macroscopic classification is cortical bone and cancellous bone. The microscopic classification is woven bone and lamellar bone. So next, let's move on to the bone cells. There are three types of bone cells that all of us know of. One is osteocyte, which is the most abundant cell in the bone, which is about 90% of all cells. The second one is osteoblast, which is responsible for bone formation and bone matrix formation. The third type of cell that we commonly see is called as osteoclast. So these are the three different types of cells that we see in the bone. So let's begin with osteoblast. Osteoblast is basically derived from mesenchymal stem cells. All of us know this. It goes through a series of changes from an osteoblast progenitor to pre-osteoblast, and then becomes the osteoblast finally. Okay, so the osteoblast lays down non-mineralized matrix of the bone. Okay, it produces three It produces the following products. It produces what is called as alkaline phosphatase. It produces osteonectin. It produces osteocalcin. So these are things it produces for laying down the non-mineralized portion of the bone matrix. It also plays a very important role in regulating osteoclast function. Now let's move into the rank ligand mechanism through which bone signaling occurs between the osteoblast and the osteoclast. So what basically happens is the parathormone stimulates the osteoblast, PTH stimulates the osteoblast, and the osteoblast produces what is called as rank ligand. This rank ligand acts in two ways. It acts on progenitors of the osteoblast to stimulate osteoblast formation itself. So this is not important for us, so you don't have to remember this. What basically the rank ligand does is it attaches to the rank receptor. Remember this. The rank ligand attaches to the rank receptor on osteoclast. It attaches to the rank receptor on the osteoclast, and it stimulates the osteoclast and activates it, and then it produces what is called as a ruffled border, attaches itself to the bone and causes bony resorption. How can this action be prevented? A rank ligand monoclonal antibody can be produced by what is called as denosumab. So it acts on the rank ligand. Denosumab is a monoclonal antibody against rank ligand. It is given once in 6 months in subcutaneous form. It's a very effective treatment against osteoporosis. So denosumab is used in two conditions. One is in osteoporosis, and the second condition that it can be used is in, it can also be used in giant cell tumor of the distal radius. So these are the two conditions that it can be used in. Osteoprotectin is a molecule produced by the osteoblast which attaches to the rank ligand. So it acts like a rank receptor. It is called as a decoy receptor. What is it called? It is called as a decoy receptor. So it attaches to the rank. It's called as a decoy receptor. It attaches to the rank ligand and prevents the rank ligand from attaching to the rank receptor, and therefore prevents the activation of the osteoclast, and therefore increases bony resorption. So this is the function of osteoprotectin. Osteoprotectin is a decoy receptor. Osteoprotectin is a decoy receptor. There are many questions asked from this section, so therefore we have to be careful, and we just go through a recap of this. First is that the parathyroid hormone stimulates the osteoblast, which produces the rank ligand, which attaches on the rank receptor, which is present on the osteoclast, stimulating and activating it. Osteoblast also in other conditions can produce osteoprotectin, which attaches to the rank ligand. The osteoprotectin acts like a decoy receptor and prevents the rank ligand ever attaching to the rank receptor on the osteoclast, and therefore does not help cause the activation of the osteoclast and thereby decreasing bone resorption and increasing bone formation. Moving on to the next cell that we have, it is called the osteoclast. Osteoclasts are derived from the monocyte macrophage lineage or the hematopoietic cell lineage. They are different lineage from the osteoblast. That must be remembered very clearly. So they multiple of these cells form join together to form a multinucleated osteoclast. So once the osteoclast is activated based upon the rank ligand system, it attaches to the bone and it migrates and attaches to the bone, and it forms a ruffled border here. So the edges, it increases the surface area of the cell. Okay, so it attaches to the bone, and this is called as a Hauschip's lacunae. This is called as a Hauschip's lacunae. Here it produces various enzymes including TRAP. It produces an enzyme called as TRAP. It is called tartrate resistant acid phosphatase. This digests and breaks down the hydroxyapatite. It also produces an enzyme called as cathepsin K. So what are the two enzymes that it produces? TRAP and cathepsin K. So cathepsin K dissolves the organic matrix, whereas TRAP helps in the dissolving of the inorganic matrix. Cathepsin K helps in the dissolving of the organic matrix. So osteoclasts are an important part in maintaining the homeostasis of the bone. Osteoblast lay down the bone and osteoclast remove the bone. So if osteoclastic activity is disrupted in some fashion, then you have an increased laying down of bone like it happens in Paget's disease. So so osteoclast and osteoblast homeostasis is very important to maintain the bone production and turnover at a regular basis. So next cell that we're going to see is called as osteocyte. Osteocytes form about 90% of all cells in the bone. So they are the predominant cell variety in the bone. And osteocytes are previous osteoblasts which have finished their function of laying down bone. They settle down, become more dormant, and they form or they are present in the lamellar layers of the concentric circles of the Haversian canal. So the Haversian canal is a central canal through which the arteries, nerves, and vessels pass through. Then you have the lamellar structure around it in a concentric fashion, which have embedded osteocytes in them. The osteocytes communicate to each other using through the canaliculi, and osteocytes maintain the function of the bone. However, they do not play a major role either in bone formation or resorption. The major difference between osteoblast and osteocyte is that osteocyte do not produce alkaline phosphatase. They do not produce alkaline phosphatase. So a lot of questions are asked between the differences between osteoblast and osteoclast. This must be well known to all of you. So an osteoblast is a bone forming cell, whereas an osteoclast is for bone resorption, right? And osteoblast develops from the mesenchymal stem cell lineage, whereas an osteoclast is derived from monocyte or macrophage lineage or hematopoietic lineage. Osteoblasts are small uninucleated cells, whereas osteoclasts are large multinucleated cells. The osteoblasts are involved in the formation and mineralization of bone, whereas osteoclasts are involved in the bone breakdown and bone resorption. Okay, but we must also understand that osteoclast is heavily regulated by the osteoblast through the rank ligand system. So now let's move on to the bone matrix. What are the contents of the bone matrix? Bone matrix is made up of organic material, which is about 40%, inorganic material, which is about 60% of the content. So inorganic material is much more than the organic material. Organic material, let us finish the first part, contains collagen, which is 90% of the material, and then proteoglycans and matrix proteins. So these are three components, of which type 1 collagen is of the highest percentage of organic portion, which is 90%. So how do you remember type 1 collagen? 1 and bone. Bone also has 1. So remember 1 and 1. So type 1 collagen is found in bone. Type 1 collagen, which consists of 90% of the organic material and provides tensile strength to the bone matrix. Then we have proteoglycans. These are glycosaminoglycan complexes, and these provide compressive strength to the. So other matrix proteins are all osteocalcin, osteonectin, and osteopentin. Among this, the most abundant protein is the osteocalcin. This has to be remembered. So the most abundant non-collagen matrix protein is osteocalcin. The most abundant non-collagen matrix protein is osteocalcin. So the inorganic materials, the rest 60% of it, the most important component of this 60% is calcium hydroxyapatite Ca10PO46OH2. This has to be remembered. Sometimes this formula is itself asked as a question. It has been asked previously. It can be asked in the future as well. So the most common inorganic component is calcium hydroxyapatite Ca10PO46OH2, and the other smaller portion of it is brushite. So the inorganic portion forms or gives compressive strength to the bone matrix. So the bone matrix is formed by two components. One is organic, which is 40%, inorganic, which is 60%. The organic portion is mainly made up of collagen type 1, which gives tensile strength to the bone, proteoglycans, which is made up of glycosamino complexes, which gives compressive strength to the bone. Then you have matrix proteins, among which the most abundant one is osteocalcin. The inorganic portion mainly consists of calcium hydroxyapatite, which gives compressive strength to the bone, and brushite, which forms a smaller component of the bone matrix. So coming to the bone circulation, briefly, there are three major circulatory systems in the bone. One is called as the nutrient artery. So one is the nutrient artery. The second one is the periosteal arteries. The third one is a metaphyseal epiphyseal artery system. So majority of the blood supply comes from the nutrient artery, which is a forceful or a high pressure system, which enters the nutrient foramen of the bone and then gives rise to the ascending branch and the descending branch. Ascending branch and the descending branch. And then it supplies blood to the inner 3/5 of the bone. Inner 3/5 of the bone. Whereas the periosteal arteries supply the outer 2/5 of the bone. Outer 2/5 of the bone. And this is a low pressure system. The periosteal arteries are the low pressure system. The metaphyseal and epiphyseal vessels supply the area of the epiphysis and the metaphysis. The metaphysis is the most vascular area. It has the most blood supply, and therefore there is an increased chance of infection in children in the metaphysis. So this is what we should remember. This is a clinical point, and this is why Brodie's abscess and acute osteomyelitis occur more frequently in the metaphyseal region. So the nutrient artery gives most of the blood supply to the bone. It gives the inner 3/5 of the blood supply, and it enters the nutrient foramen, gives out an ascending branch and a descending branch, and this is disrupted in fractures. The nutrient artery, nutrient foramen is disrupted in fractures, where the blood supply is then taken over by the periosteal low pressure system, which supplies the outer 2/5 of the cortex. Let us, in very brief, discuss about embryology. The few things that you should know at your level is, one is the limbs are formed between 4 to 8 weeks during gestation. The lower limb lags the upper limb by 2 days. So by 2 days, that means the upper limb is formed faster than the lower limb by 2 days. Okay, so there are three main zones or areas which can be damaged in case of the forming limb. The first one is called as apical ectodermal ridge. That is the tip of the apical ectodermal ridge, or AER. This is responsible for the proximal distal growth of the limb. So if the limb is shortened, or if there is a congenital amputation of the limb, that which occurs in phocomelia because of thalidomide poisoning, this used to happen very frequently in the 70s and 80s, and this is called as apical ectodermal ridge damage. So any damage to this portion of the growing limb bud can cause congenital amputation of the limb. Second is called as a zone of polarizing activity. Zone of polarizing activity is ZPA, which is responsible for radial and ulnar differentiation. So if there's a problem with this zone, you can have what is called as extra fingers formation, loss of fingers, for example, like radial club hand, polydactyly, and mirror hand. So these things can occur because of a problem to the zone of polarizing activity. And the third thing is called as a WNT. WNT is responsible for dorsopalmar. That means differentiation between the palmar aspect of the hand and the dorsal aspect. If this is not functioning, or the WNT system is affected, it can cause palmar and dorsal defects, and this occurs very commonly in nail patella syndrome, where the nail is nail patella syndrome, where the nail is volar rather than dorsal. So the three components of the growing bud which can be affected are apical ectodermal ridge, which is responsible for proximal distal, for the length of the limb. The second one that can be affected is called ZPA, or zone of polarizing activity, which is responsible for radio-ulnar differentiation or mediolateral differentiation. And the third thing that can be affected is called the WNT or dorsopalmar differentiation, which is responsible for nail patella syndrome. So let's move on to a few questions just to represent the topic that we have studied, and let's go through a few of these questions to understand the topic better. So let's begin. Which of the following cells secrete osteoprotegrin? So we know very well now that osteocyte is not very active, metabolically active, so this we can rule out comfortably. Osteoblast, yes, osteoblast produces osteoprotegrin. Osteoprotegrin, what do we call osteoprotegrin? It's called a decoy receptor. So the rank ligand is produced by osteoblast, which inserts into the rank receptor of osteoclast, and it activates osteoclast. But when osteoprotegrin is produced by osteoblast, it binds to rank ligand itself and prevents the activation of rank receptor on osteoclast, and thereby decreasing bone resorption. So the correct answer is osteoblast. Okay, it's not osteoclast, it's not proto-osteoblast. Okay. So what is the mechanism of action of calcitonin? Calcitonin acts directly on osteoclast and inhibits its activity. Calcitonin acts on osteoclast directly and it decreases its activity and thereby decreases bone resorption and increases bone formation by osteoblast. So the first question option is correct. So let us see this question. It's a very important question, very often repeated, so you must understand this question. A 75-year-old lady presents to you with arm pain and an X-ray as shown. She has undergone previous breast surgery for cancer. What is the pathology pathway through which this lesion occurs? So you can see a lytic permeative lesion which is non-expansile in the upper third of the humerus. So we know that she's had breast surgery for cancer, so most likely this is a metastasis, which is a lytic lesion occurring from the breast. So it has been shown that rank ligand is the pathway through which this occurs. That is, increased osteoclastic activity through the rank ligand pathway and increased bone resorption is what causes this metastasis-led lysis of bones. So the rank ligand pathway is the answer. Interleukin-1 is known to cause osteolysis as well, but it does not cause osteolysis in this or metastatic condition. It is known to cause osteolysis in other conditions. Osteoprotegrin does not cause osteolysis. In fact, it prevents osteolysis by binding to rank ligand and preventing the rank ligand pathway. Sclerostin inhibits osteoblastic activity. It has no relation to metastasis-induced lytic lesions. So the correct answer is rank ligand pathway. So next question, very simple question. Rank ligand is produced by, so basically we know this very clearly now, rank ligand is produced by the osteoblast. It binds to the rank receptor on osteoclast and it activates osteoclast and causes bone resorption. So the correct answer here is osteoblast. So both, so the thing to remember here is OPG, that is osteoprotegrin, and rank ligand. Both are produced by osteoblast. Both are produced by osteoblasts. Next question is, all the following inhibit osteoclast activity except. So let's go one by one. TNF alpha, we are not sure, so we will come back to this. Osteoprotegrin. The spelling is wrong here, but the thing is osteoprotegrin, yes. Osteoprotegrin binds to rank ligand and inhibits the activity of osteoclast. The next one is denosumab, yes. Denosumab, it binds, is a monoclonal antibody to rank ligand and inhibits osteoclast activity by preventing rank ligand binding to rank receptor. Bisphosphonates inhibit osteoclasts and prevent bone resorption. Calcitonin, yes, calcitonin acts directly on osteoclast and inhibits bone resorption or inhibits its activity. So all these three are osteoclast inhibitor. TNF alpha is the correct answer because TNF alpha is not an osteoclast inhibitor. How does mesozoium function? Mesozoium is a monoclonal antibody against sclerostin, so it inhibits sclerostin. So sclerostin inhibits osteoblast function. Therefore, an inhibitor of an inhibitor increases osteoblast activity. So therefore, the correct answer for mesozoium is it inhibits sclerostin. Which of the following arteries provide blood supply to the outer one-third of the cortical bone? So we just went through the topic. The outer one-third is supplied by the periosteal arteries, whereas the inner portion is supplied by the nutrient arteries. So to recap, so this is a bone. We have the nutrient artery which enters, divides through the nutrient foramen, divides into the ascending and descending branches and provides the inner 3/5 blood supply. The outer portion is supplied by what is called as a multiple arteries called as a periosteal arteries, which supplies the outer 2/5 or outer 1/3. So the correct answer is periosteal arteries. So next question is, which of the following combinations provide tensile and compressive strength respectively? So this is a factual question that you must know. The tensile strength is provided by type 1 collagen mainly. It is a matrix protein and it provides strength, whereas a compressive strength is provided by the inorganic matrix, and that is a calcium hydroxyapatite. So let us look at the bone matrix. Bone matrix is divided into organic matrix and inorganic matrix. Organic matrix forms 40% of the amount of the matrix, whereas inorganic matrix forms 60% of it. Organic matrix is made up of type 1 collagen, it's made up of proteoglycans, and made up of matrix proteins like osteocalcin, osteopectin, and osteonectin. Whereas inorganic is made up of two components mainly, calcium hydroxyapatite and brushite. Among these, type 1 collagen helps in the tensile strength of the bone, and calcium hydroxyapatite helps in the compressive strength of the bone. You look at this picture and determine from which lineage this cell is derived. Which lineage this cell is derived. You can see a small cell here. It is multinucleated. There are multiple nuclei. So which cell is multinucleated in the bone? It is the osteoclast. It is the osteoclast. So from which cell is this obtained? Which lineage is this cell obtained from? It is obtained from the hematopoietic stem cell lineage. Hematopoietic stem cell lineage. The answer to this question is hematopoietic stem cells. Coming to the cut. Which canal or system in the osteon is used to transport blood vessels? So which is the system in which the blood vessels are transported? It is the Haversian canal. So Haversian canal is in the longitudinal axis of the bone, and it contains the blood vessels and nerves in the osteon, whereas Volkmann's is transversely oriented to the bone. It connects between two different osteons. So the correct answer to this question is Haversian canal. So canaliculi are interconnections between the osteocytes. Volkmann's canal are transverse connection between the osteons. Haversian canal is oriented around the long axis of the bone and is the one which actually contains these vessels.